Well, Dr. Hartman, such a pleasure to have you as a first in-person podcast guest.
I'm super excited to be here in your amazing podcast studio.
Thank you. Thank you. And we were talking before we started recording about some of the anomalies that you have the opportunity to see. And I think as a triple board certified physician, you are in a very unique perspective to see not only common issues that your patients experience, but also some of these anomalies, these things that maybe some of us saw in a book during our training. Yes, back when we were in training, we saw things in books. Nowadays, everything is online. You know, in terms of working with middle-aged women, which I know that you work with quite a few, and I've publicly disclosed that you are also my personal physician. I know that there's a lot of focus on this bidirectional relationship between our gut and our brain. And when we're speaking specifically to the microbiome and the changes that are occurring in women's bodies as they are navigating perimenopause and menopause, how commonly are you seeing mood issues, anxiety, depression, obsessive compulsiveness that kind of get triggered at this stage of life when their bodies are having fluctuating sex hormones and other types of issues that can go on?
I mean, it's more common than not. I almost 80% of the time, maybe it's a part of the story. The way I explain to a lot of people is, if you're a female, you've raised kids, you have a career, how many moms, in their mid 40s to 50ish, how many are not doing 20 to 30 things at a time? And so you're running on cortisol, you're pushing it and pushing it. And so when all of a sudden your estrogen starts to get wonky, progesterone goes down, your testosterone goes down. Many times, actually, even the pregnenolone, which is the primary memory hormone, which often is not looked at, starts going down. Like, how would you feel? You're going to have loss of tolerance for life. You get anxious easier and quicker. Your threshold for, getting upset, well, whatever that might be in your household, looks like goes down. So all of a sudden, you're triggered quicker and easier. And then when you have that triggering event, it takes longer to calm down. So it's a pretty, I don't want to say universal, but it's unusually common. I was actually talking with my wife, who you're friends with, and in their group, it's like this common thing where like no one told us this was going to happen. No one told us that all of a sudden, we weren't going to tolerate life and things were going to go crazy. And I don't want to say things were going to go to crap, but kind of sort of, and I think the common experience is you get to this stage, and unfortunately, it's happening younger. Mm-hmm. It used to be, 46 to 52. Now it's, 43 to 45. And then you have some women who start losing their progesterone and testosterone in their mid to late 30s. So it's a pretty big age range to see stuff based on your experience and your chemical exposure and how many children you had and fertility issues and PCOS and endometriosis and all things hormonal, which are the new normal, right, can affect that. But to have some kind of mood imbalance, it's, I don't want to say it's universal, but it's too common. It's too common.
And it's interesting because I feel like what I have experienced is this general irritability, whether it's a function of the estrogen dropping and our people-pleasing tendencies kind of go along with that, but I have no filter anymore. I think it's a source of endless embarrassment. And it's something that my girlfriends and I laugh about is I almost can't not tell people what I think. Like, whereas before I might've been more restrained, I might have thought more about what they would think of me. I'm very polite about it, but my kids sometimes will be like, don't do it. Please don't do it. We're in a store and I'm like, but if you just could have asked it in a different way or, providing constructive feedback, maybe when it isn't necessarily appreciated. But I look at it as, it's this dual-edged sword of, we're getting to the, affectionately as people call it, the I don't give a shits anymore. It's just you're much less inclined to be people pleasing. And what I see as an overall kind of gestalt of irritability. And it could be, also the sandwich generation. We've got kids who are older. Our parents are getting older. You may be in a position where you have more work responsibilities or home responsibilities, and you just feel like there's not a break in sight. And that is certainly what I hear a lot of my girlfriends experience. And I have some friends who are empty nesters now or open doors, depending on how you like to rephrase it. I have others who maybe started a little later, and maybe they have elementary school kids that they still have at home, but they're kind of in the stage of life that I'm in. And so I think it so much of that experience is our perception of the aging process in general.
But those are all true things you said, but there's also the concept of that. I think we're just exposed to more these days. Since, not to make this conversation political at all, but I have patients who are coming to me now that are unusually anxious, and their stuff is going on. And it's like, well, I actually recommend it to a couple of them. Jonathan Haidt, the anxious generation, remove technology, right? And they're like, but that's kind of how we got here in the first place. And they feel this like, I have to stay engaged in order to somehow they're going to prevent like the dealing, what's going on in the world right now. And like, it's like social media, it's news, it's podcasts.
Mm-hmm.
Again, this is something my wife educates me a lot about, what women in the mid 40s think about, but evidently in her age range, like murder podcasts are a thing. Yeah. She goes to bed listening to these things.
Interesting.
And for her, it's like control. Like if I know how bad things happen, I can better protect my family. I'm like, wow, that's kind of okay. And in her world and her people she talks to, that's like a thing. And I'm like, okay, I don't think that's helping your anxiety level, but if that gives you a sense of control, then, but it's like all these things that when you're 20 and 30, not a big deal. But all of a sudden it's what used to be your superpower that enabled you to grow life in the womb and raise it and not sleep, because the reality is women still today bear the brunt of all that. And oh, by the way, you have to have a career and you have to have all these things and all that kind of stuff. And it's like, how oh my gosh, how do women do it for 20 years? And then you lose that superpower, and it's like the cortisol's there. Mm-hmm. And the women in my practice who have the hardest time are my type A executive types, who their expectation is, no, I need to keep on firing all cylinders. The hormones cannot stop. And that's where it gets a little tricky, because the cortisol, you start checking numbers, you see the cortisol, it's off the chart. It's crazy high.
Well, and it's interesting. We become much less stress resilient. And that is certainly something, if I reflect on where I was 10 years ago, worked for a big practice in Northern Virginia. My husband was traveling a lot. My kids were 10 years younger. They were 7 and 9. I was just in a very different place, but I was doing all the things that I tell women not to do. Super intense exercise, because I didn't know any better then. Too low carbohydrate, probably not enough sleep, not managing my stress proactively. And I reflect on what my life looks like now, and it is 180 degrees different. Like last night I was in bed at 8:45. I was like, I'm tired, I'm going to bed. Were there things I could do? There's slides I have to finish for a presentation for next week. I was like, no, I'm going to bed. And I think for a lot of women, that is a hard thing to learn. That you have to adjust so many things about your life that maybe in many ways were great for you, especially if you were a type A, conscientious, go-getter, that all of a sudden everything that got you to where you are, you're like, oh, wait a minute, those things don't work anymore. That's a lot to adjust to.
It is. And when your body's changing and your hormones are changing, and then you realize the nutrient deficient. This is another thing about the hormones people don't realize: nutrient deficiencies, magnesium deficiencies that 80% of the population has. Depending on what study you look at, maybe some of these numbers sometimes are hard to like just grasp, but maybe up to 100% of Americans have insufficient potassium levels. Who doesn't have a low vitamin D level? Who's selenium, true rare earth minerals, trace minerals, molybdenum, lithium levels. You need lithium for mood stabilization. You're supposed to get this from the natural spring water we consume. Like, who does that anymore? And all of a sudden, all these things that build up over decades, and then your hormones, then your superpower goes away. And it's like, and this is one of the things I see in patients I do hormone optimization versus hormone replacement therapy with, is that yes, you're now off in this, but you have to build all this foundation back. And if you just replace estrogen and progesterone and bring the cortisol down, you won't see the same benefits if you don't also get. In Virginia, I see so many people with basic iodine deficiencies. Mm-hmm. It was supposed to be gone. We were supposed to fix that with iodinized salt. I see it routinely. And it's like, how is your thyroid going to work? How are your other hormones going to work if your iodine, one of the essential halides, is deficient? And so a lot of what you have to do is not just, before you do this, actually, you need to replace what's lacking. Work on the gut, which started this whole thing, because your serotonin, which is your Zen neurotransmitter, 90% is made in your gut. 75% of all neurotransmitters are made in your GI tract. And I'm actually reading it right now. You know me, I'm got nothing else to do. So I'm reading a textbook. I'm actually reading a textbook of dysautonomic medicine right now. Yeah. And I realize there's 5 parts to the nervous system. And one of those, we used to, there's the sympathetic, parasympathetic, there's the noradrenergic, there's the the adrenal, which is basically the brain connecting to your adrenal gland, and then your enteric nervous system. And we kind of always just clump them together. Like, yes, they're part of the autonomic, but they are actually their own systems outside of the sympathetic and parasympathetic gut. And 80% of the interaction between your brain through the vagus nerve and your gut is actually sensory back to the brain. And so your gut health, it's not when you get anxious, oh my gosh, my gut's messed up. We used to say 30 years ago, you're anxious. And that's the reason why you have IBS symptoms. Well, now probably that's not the case. It's primarily a enteric nervous system thing where, again, 50% of dopamine made in your GI tract. That's the reason you're feeling anxiety. Most likely not the other way, which is exact opposite of what I was told in medical school, 20 some years ago.
Yeah, no, I think everything really originates in the gut microbiome. I think that is, especially after just writing this book and understanding what is changing in the terrain, especially with these, shifts in sex hormones, in particular estrogen. That's probably the hormone we know the most about and its interconnectedness with immune function. And so when you are working with women at this stage of life, and as you astutely mentioned, you have this kind of foundational approach to ensuring that their trace minerals, their micro macronutrients are all optimized before you're adding in hormones. And I think that's pretty unique. And especially because I have the opportunity to connect with so many experts on the podcast, I think it probably is a huge differentiator between yourself and a lot of others that are just, slam bam, thank you, ma'am. It's a terrible way to explain it, but you go to see them, they give you your progesterone, maybe some testosterone, some estrogen, they send you on your merry way and you're not feeling better. And much of that can be attributable to a constellation of issues that I'm sure we can unpack. But I do think that if we're not dealing with things on a very foundational level before we start adding in hormones, things will not be optimal.
Yeah. And you mentioned the gut initially. If there's a thing called the strobilome, which is the metabolism of estrogen, and there are bacteria in your gut that actually create these enzymes. And they actually, if they're out of control, your body naturally detoxifies estrogen. Your liver takes it, puts it in bile, you put it in the GI tract, and you're supposed to, defecate it out. If you have too many of these bacteria, and you can actually measure this in a stool test with a beta glucuronidase level being elevated. If that's high, then all of a sudden, this female most likely has estrogen dominance. You have fibrocystic issues, breast tenderness, history of fibroids, endometriosis type issues. And all of a sudden, how many people is that?
A lot.
And so if this is elevated, that's a simple fit. I mean, you have to work on the microbiome, but you can literally use calcium D-glucarate as a part of now you need to fix the gut and other things, but all of a sudden there's little biohacks, so to speak, that you can use to address that one small piece of this, your body's ability to detoxify estrogen, which if you don't do it the right way, and if you go down the wrong pathway, you make too much 16 or the 4, 16. Yeah. But all of a sudden you might be taking something good and turning it into something bad, which, there's some, I think it was 2018, 2019, some research came out showing that women on bioidentical hormones, if you're diagnosed with breast cancer, it's less aggressive. So all of a sudden now were we wrong? Were we wrong for a quarter of a century? Our actual bioidentical hormones breast protective, with literature is now going that way. And it's actually us doing oral dosing, super high doses, including synthetic progestins like medroxyprogesterone, which we know causes tumor in lab rats. And then the initial group that the Women's Health Initiative was women 65 was the average age, and a lot of them were smokers. So it was kind of like all these things, in medical school, you shouldn't smoke and take birth control pills. But when we did that big study in Canada, we left smoking women on oral hormones in, and we were surprise, that you saw clots and breast cancer, and no one ferreted that out appropriately. And we went down this pathway of, I was actually talking with Dr. Jinsky about this. He's a physician in the practice, and he says I'm almost steal his phrase, but he says he's becoming a medical feminist because it's like we've literally neglected all these little nuances. The idea of radical mastectomy for small cancers, that was standard of care till the last 20, 30 years. Like, there's a lot of things we've done that have neglected, let's say, adequate care or optimal care for women, particularly in this age range.
Yeah. Well, and it's interesting. There was a podcast with Peter Attia and Dr. Rachel Rubin. I don't know if you've heard about it, but even my husband listened to this entirety of this podcast. So she is I believe, a urogynecologist. And she was saying that if men's penises shriveled up and, fell off, there would be a vaccine against this. And so she was making the point of saying, yes, over the past 25 years, we have made some decisions that have not been in the long-term best thought process for women of this age group. But it's also a part of this, and I dare I say this terminology, medical patriarchy, which in many ways, in terms of looking at women's healthcare, women have accepted many things. I think that, our generation of clinicians, younger generation, will demand better care for women. But I think in many instances, Women's Health Initiative is one of many examples where women's long-term health needs were, it was like this knee-jerk reaction of, oh my gosh, these rates of cancer go up, but we're looking at an unhealthy population, obese, diabetic, hypertensive, previous smoking history, 10 plus years into menopause. It's a very different population of women than when it's initiated. HRT is initiated earlier.
But also doing it by mouth oral.
Yes, very different.
Which goes to your microbiome, and a lot of metabolites are made through your liver. Because of the way it's metabolized, you have to dose it higher. Mm-hmm. So you're dosing milligrams versus, you're dosing really high doses, 3-4 milligrams versus, micrograms. And all of a sudden it's like, well, maybe too much by mouth through your liver. I mean, we figured this out with men. And testosterone, methyl testosterone used to be a thing. We used to do it by mouth, and then liver cancer. Yep. And it's like, well, maybe, is it possible that estrogen and progesterone might do that? That never occurred to anybody. That maybe, just maybe, doing those by mouth might have some bad, Now it's interesting for progesterone because actually doing progesterone by mouth, your liver will, and this is the unique, when it's actually better, it will turn into allopregnanolone, which actually is very calming, so it can actually help with sleep. So actually, and one of the metabolites from oral progesterone is breast protective.
Yes.
So all of a sudden it's like, you want to do that, but you don't want to do this. And so that's where it gets a little nuanced. And I still have patients coming to see me who other practitioners are giving them like sublingual estrogen. And I'm like, well, you still swallow a lot of that.
Yeah.
Yes, you do get, some
first pass effect.
Yeah. So it's one of those things where are the people learning stuff routinely, on a weekly, monthly, yearly basis. I think a lot of it just what you mentioned I learned this. I didn't figure this out on my own. I learned this from other people, and I just kind of pieced it together. So I think it's just the way you keep this. Things are changing. I tell people all the time, you can't hold anything safe to me more than like 3 to 5 months because you might come back and I'll change because I'm just always learning. And
I think that's the case that, that evolution of a clinician, that you are not practicing the way you did in 1995. It's very different than the way you practice now. Like I tell people, I'm not the same nurse practitioner I was 10, 15 years ago. And I'm grateful for that because of that learning process. What I find interesting is I'm starting to see some clinicians that are using oral estrogens to protect bone and brain. And so that seems to be there's like an undercurrent of discussions ongoing about this. And I'm sure that there might be a particular patient that's appropriate for, but it seems like that is starting to become a thing in terms of wanting to get serum levels to a certain amount. I know you and I have talked about this, separately. It's like trying to help women understand, is it more important that we treat for symptoms we experience in perimenopause and menopause, or are there thresholds we need to meet to be able to protect bone, brain, and heart health? And that's where I feel like there's a lot of nuance right now. And I don't per se think there's necessarily a right or wrong answer. I think that clinicians are trying to figure out what is the best offer for each patient.
Well, I think that's the key is for each patient. You have to individualize it. And if someone comes in and has sleep apnea and they are pre-diabetic and they're really stressed out and they're 52 and they've been going through the change recently, then you can give them a lot of oral estrogen, which I've seen locally in some of the clinics, and you will cover those symptoms and they'll feel better for a year or two. But if you don't deal with all the other stuff, then what happens is your body, and then there's the whole thing of this thing called the estrogen receptor. Like in nature, and this is one of the things that kind of like makes sense, but why isn't this not common talked about? I mean, I was taught it by experts in the field that, when you are cycling, there's a period, 5-7 days a month where all your hormone levels kind of, except for testosterone, will go down.
Yep.
And all your receptors kind of reset. One of the things that it's not a true type of tachyphylaxis, but you get like a hormone resistance. Your estrogen's all as high, your testosterone's all. We see this in men, in professional bodybuilders and people that have used testosterone. After a while, like that 800 level, 900 level just doesn't do it for you. Now you need 1,000, now you need 1,200.
You're chasing that high.
Yeah. And so what happens is if you don't take a break where you at least, 3 to 4 days a month, then what happens, you develop this tolerance. And how many people doing the oral stuff aren't taking that little break? And the answer is, as far as I know, like that's the norm. And so there's all these little nuances to it that, that's the reason I like to use the word hormone optimization, not replacement, because the ideal is to make it optimal for the person in front of you. And if you have thyroid resistance, if your reverse T3 is elevated, if your TSH is, 4, which is normal, and your, free T4 is like, 1.0, which is normal, which is low normal, all of a sudden, all this other stuff downstream is not going to work quite as well for you because you're in a relative, not quite technically subclinical hypothyroidism. But for some of my patients, if their thyroid's off like a point or two, they feel it.
Well, and it's interesting because I kind of reflect on what I've learned working with you, and then, what I've learned through continuing education and talking to other experts. And that one, 3 to 4 days a month of a break of oral progesterone, for me, it's Friday night. I'm like, Friday night, I know it's like Saturday's usually a less stressful day. So if I don't get my progesterone on board, and what I've come to find is that by being conscientious about the day of the week in which I hold my oral progesterone, my sleep actually isn't bad. And I think it's because I've learned like, what are the other things I need to tweak? But I also do it on a night where if I don't get a stellar night of sleep, it's not as big of a deal as opposed to a regular, Monday through Friday work day.
And one thing I'll say, since you brought it up, I didn't mention that I see you anywhere, so I still mention that. But that's on you. I didn't mention that.
Yep.
You broke the confidentiality there.
Yep.
But the thing is that you have individual, and you're not alone. Where the oral progesterone, there's some women based on microbiome issues that they can't tolerate.
Yes, the progesterone resistance.
Yeah, they have issues with it, and you have to do topical. And then in some of those women, I've noticed, I have a few of them that. It's interesting. Their skin absorbs it so well. I'm giving them these ridiculously low doses of topical. And sometimes it's like, this is just 10 milligrams of topical progesterone. This is like nothing. And yet their levels are high when we do their testing. And so that's where, again, back to the individualization, personalization, like just because this is the textbook best thing for women, it might not be the best thing for the person in front of you.
Well, and progesterone resistance, from what I understand, is a real entity. I know that when I interviewed Dr. Lindsay Berkson, she was mentioning that sometimes she recommends women use it both transdermally and then also intravaginally to get their progesterone levels where they need to be. So if there are women listening that have experienced taking oral estrogen and they're edgy, they feel anxious, they just don't feel good, you might be someone that is exquisitely sensitive to progesterone's effects. And I always say, like, I'm so sorry, because progesterone is one of those things that's like one of my favorite things I look forward to taking right before bed, because it is, for me, it helps fall asleep. I feel very relaxed. And that's exactly the mode that I need to be in prior to falling asleep. When we're thinking about testing, and I kind of touched on this in particular, when you are working with a new patient, you're working with a middle-aged woman, what are some of the low-lying fruit tests? You mentioned some of them, some of these cofactors, some of these vitamins, minerals that are so important, iodine in particular. But where does gut testing, stool testing fall for you? Is that a very important kind of first step when you're working with someone that comes to you that is, trying to, optimize how they're feeling? They're not feeling as good as they did in their 20s and 30s, but they know that, that there are certainly options out there to optimize how they're feeling and to improve, whether it's energy, sleep quality, vitality, loss of muscle, loss of libido, all these different constellation of symptoms women experience.
For me, it depends. So if someone's coming in and they're like, I'm an optimization patient. Yeah, then it's one of the first things I do, because it's gut super important. But the person comes in and they're like having, anaphylaxis and weird skin things, and they're having a bunch of chronic fatigue, and they just got over long COVID, and they pulled a tick bite, tick off their body, 3 weeks ago. Yeah, I know. It's like, you know what, your gut's a mess right now, but this is going to confuse the picture, because you're going to get this 12-page report back with a lot of little things on it that are going to confuse you. And then we're going to go down this rabbit hole. Let's do, like, I know that gut is foundational, But that's where I think working with someone longitudinally,
Mm-hmm.
where you don't have to do everything in one visit. And it's also like reading the patient, developing a gestalt, let's say. Actually, I'm reading another Jonathan Haidt book right now called The Righteous Mind. And it's really an interesting read because I'm sure if you're familiar with his work, but the idea is that what he's discovered is intuition is actually more powerful than our prefrontal cortex stuff. It's the analogy he uses is the man on the elephant. And the man is like our consciousness. Like, I'm thinking I'm going to do this, but the elephant actually is your intuition, which is actually the beast of burden. And a lot of times, and then there's other neurobehavioral research that, most decisions are emotional. And then you try to convince yourself that's the right decision. There's this interesting thing where they had these patients that actually had damaged amygdalas. And so the limbic system was dysfunctional. They could make it like I made a decision, but they couldn't actually do it. They could say, this is what I'm going to do, this, and this. But the ability to actually like go through requires that emotional component. So it depends on where the person's at in that whole thing. And so if they're like in a place where they're just 100%, I'm just here for personalized precision medicine, I want you to optimize me, then we're going to do we're going to do hormones. We're going to do salivary hormones. We're going to do cortisol. We're going to do the 3-point cortisol in addition to the gut test. And then all the nutritional stuff. One thing I think is commonly overlooked are fatty acids.
Yes. Because
it's just now, I think C15 is just now coming into public consciousness, which is, I could talk about that for a long time. I think that's a great example of how following government regulations and recommendations has resulted in a nationwide nutrient deficiency, low fat.
Yep.
We did that for 40 years. Removed dairy, which is the primary source for C15, and 30% of the population is deficient. Oops, how many times do we do that? But the point is, fatty acids and all these hormone receptors we've talked about all sit in cell membranes. If the membranes are dysfunctional, then all of a sudden, when something binds onto that, it's not going to quite work. And so you need your omega-3s and 6s balanced. And inflammation's all the rage. If your 6s are really high or your 3s are really low, you can have a similar inflammation presentation. And so balancing those saturated fats, which actually are the main things that stabilize your cell membranes. If you don't have adequate, it's crazy. I'll see people routinely who, when you do a fatty acid analysis, have low levels of saturated fats in their cell membranes. Like, these are essential for a reason. We call them essential fats. And so all of a sudden people are like, oh, my hormones adjusted. It's like, you need more BAHIC acid. You need more of these other saturated fatty acids. You need your DHA is like, super low. Like, no wonder you have issues with cognition and thoughts. So that's where, putting all these things together. But the basic thing, yes, if anything's pretty good with you, yes, the gut test is one of the first things I do. But that tends not to be my experience. My experience is patients come in with their undiagnosed dysautonomia and all these other kind of things. And I'm trying to do things even more foundational, which like maintaining blood flow to your brain so you don't feel like you're going to pass out. That's even more basic than, gut, I think, Do
you remember one of our first conversations we had, and for listeners, Dr. Hartman and I are friends, and our spouses are friends, and we were out to dinner, and you and I were talking, and you looked at me, you were like, and it was like, we were having a conversation and you were like, do you have a high arch palate? And I was like, what? And you were noticing things, anatomically, you were looking at me, and I think you probably are someone that has this constellation of hypermobility, dysautonomia, and you were the first person, and gut issues, which that trifecta is me in a nutshell. You were one of the first people that actually put those things together for me. And you touched on the term dysautonomia. So let's talk about this, because I think things like POTS, which I saw a lot of in cardiology, this, postural orthostatic hypotension, which can be quite significant and profound. It's a continuum. And so when you introduced you might be dysautonomic, I was like, no, I'm not one of those patients, because I saw the extremes.
Yeah.
But the irony is, when you started having that conversation with me, it made me realize, like, why have I always craved salt? Why am I one of these people that's always had, low blood pressure, but my pulse rate and my blood pressure didn't kind of coordinate together? So let's talk a little bit about dysautonomia. And you have my permission to kind of interject some of the things that kind of tipped you off that I might be one of these patients?
It's Gestalt. There's a great book by Malcolm Gladwell. It's called Blink. Yep. It talks about how experts think. And like the whole 10,000 hours kind of thing, whether you believe it or not, the idea is you get a feel after a while. And that's back to the whole intuition where you get this gut feeling. It's not emotional. It's actually based on the sum total of your life experience. And then the goal is figure out why you had that feeling. Yep. And that might take months and months and months to figure out. And then you're like, aha. And so, you get this feeling. So someone had, I get anxious. I'll be sitting down, and all of a sudden overwhelming anxiety comes over, and then I can't calm down for a long, long time. Or sometimes I'll be sleeping, or I'll be laying down. All of a sudden my heart starts to race and I feel it while I'm laying down. Or I'll wake up, I'll be sleeping and wake up in the middle of the night, like wide awake, maybe a little panicky. Or a version of that severe version, like you mentioned, Gulf War vets will have night terrors where people will actually have these like horrific dreams that will cause them to they'll give them poor sleep. There's different nuances to it. As far as the face, looking at people's faces, it's amazing if you start looking at people's facial structures. Your head's big, your mid face is a little smaller, your chin's a little smaller. Well, and then if you look from someone's side, you should have the top teeth and bottom teeth come together. One of the things that Weston A. Price, which discovered, this is a dentist that traveled the world, maybe 70 years ago, he realized that based on nutritional status, people would not need orthodontics done. They'd have really wide palates, wide dental arches. Their teeth their lower jaw would be set forward. And one of the things you see in starvation, your body preserves your brain. The next thing it preserves is your mid face, and the last thing it preserves is your lower jaw. So one of the first things that happens is people actually develop smaller jaws, smaller airways, solely from nutritional deficiencies. Yeah. Now, where the hypermobility comes in, and so you can look at people's faces and kind of see that, if you look for it long enough, just like the whole finger things. If you look at people's fingers, you can, like, not me, but you can tell if someone's fingers are longer than the palm, or longer than the palm. Yep. It's like, and then you did that, and your fingers went backwards a little bit, and or you lean your arm back, and then it kind of goes back, or you're standing. I see this at church a lot with a lot of young ladies that'll be standing up. And my wife is like, dude, just stop diagnosing people, but they'll stand up and their knees kind of have this little backward curve. Yeah. And you're like, these are all stigmata, let's say, of hypermobility. And then you start asking questions, or people, in my case, just tell you a story, and you start hearing all these mood, anxiety, sleep, kind of stuff. I can't handle the heat very well. Like I get overheated really quickly, or I can't do sauna because I just don't do well in the sauna. Or, when the weather changes, those fronts come in, I feel it, and I get migraines, and I just feel exhausted. I'm like, this is your nervous system is not dealing with something very well. Yeah. And your nervous system regulates everything else. And then you get this gestalt. And then when you do an exam on someone, you do a bait and score, you actually get your number. And then you look in the mouth because you have someone in your office. And, or even the question like, have you had done orthotics or, orthodontics. Yeah. Orthodontics for teeth. How many teeth have you pulled? If someone had like 4 to 5 teeth pulled to make them fit in their mouth is too small.
Did you ever ask me how many teeth I've had pulled?
I think I did. I think I didn't put in your chart somewhere. I don't recall off the top of my head, but
it was 4 adult teeth.
Okay.
8 teeth total. So they pulled 4 baby and 4 adult teeth for braces.
So that just means your dental arch wasn't big enough. And if you go to, the Lochenstahl Valley in Switzerland back in the 50s, which was still Europe, but it was this remote place that actually the Vatican, actually the Swiss Guard preferentially came from this place, really tall, and when Weston A. Price was there, he saw 1 cavity in every 300 to 400 teeth. So like they're basically cavityless, and no tuberculosis, which was unheard of back in the 50s. I mean, tuberculosis was still the rage. Yeah. And but part of that was nutritional and but like the thing is they had wide palates, and he has pictures of the dental stuff. And so all of a sudden, if these are small, and the thing that, okay, so what? Sleep apnea, mild sleep apnea. If you're getting disruptive sleep, it's going to affect your hormones. It's going to affect your cortisol. So this is how this all plays in. And then with dysautonomia, if your nervous system doesn't feel safe, it's dysregulated. It's having a hard time maintaining your blood pressure. Even if life is great, even if there's no issues at the home, even if you're getting 8.5 hours of sleep at night, you're still going to have cortisol and this fight or flight because your nervous system is stuck. And this is actually where some of the whole cell danger response stuff comes in play with Robert Navio's work, which is taking this big picture down to the level of the mitochondria. And that's kind of what the cell danger response is. It's this thing where literally your cells get stuck and they can't appropriately repair themselves and turn over. The fancy term is senescent cells, zombie cells or whatever you want to, the term is for the day, but that's the concept. And those cells get stuck, which is a part of chronic Lyme, a part of long COVID, a part of a lot of chronic illnesses. And the nervous system is one of the mechanisms that tells these cells, no, you need to die. So go ahead and donate your parts to the rest of the cells. Or no, you're strong, you need to replicate. When you lose that, these cells get stuck and they actually are stuck in this inflammatory, it's called a proliferative physiology where they sit and they release cytokines or inflammation. Now, all of a sudden, your nervous system in dysautonomia is programming mitochondria. And this sounds all cool, but what do you do about this? That's where breathwork comes into play with our colleague Sachin Patel. And
what was one of the things you told me, not to interrupt you? You were like, you need to do holotropic breathing. And I fought it. And in September, I did it with Sachin at an event.
Okay.
And I walked up to him and I said, you need to understand that my internist has been telling me to do this for about a year. And it was cathartic. And actually, it is what kind of, I think, in many ways, I've been able to track my HRV improvement since that time. And so for anyone that's listening, you can look this up on YouTube. It doesn't necessarily take a lot of time, but it is profoundly powerful. Yeah. Sorry to interrupt.
I actually interviewed him and we talked about this, Sachin, about this a couple weeks ago, I think. It's when it came up. But I have actually some patients who are trauma therapists. And it's interesting how people who have, it's like what you've gone through kind of draws you to help others with a similar kind of thing. And one of them, in her own personal journey, every week, part of her own personal work is her breath work. She does the holotropic, psychedelic breath work. And at the end, she's like, I have memories that I had no idea that was there. In many ways, I prefer it over talk therapy, cognitive behavioral therapy. I have so many patients who have horrible histories and they come back from the therapist triggered. They come back and it takes them days to calm down from there. And like, this is not helpful. This is like actually solidifying your traumatized nervous system. And that's one of the reasons why psychedelics have become really popular, is because it allows you to through the default mode networks and to kind of almost to disassociate your consciousness from your subconscious mind, to have kind of a reset and actually help you with that in a way that doesn't require you to get triggered. Obviously that has to be done the right way, and you have to have, it gets a little more than we want to probably talk about here, but because that can be done the wrong way too.
Yes. Yes. And that is kind of what I think has given me pause. I was speaking at an event and did a podcast with a person who remained nameless. And they were saying, oh, you really need to do this ayahuasca journey. You've got to do this. It's so powerful. And I was like, no disrespect to anyone who's done that. That might be the right decision. But I think for me personally, with my trauma history and a very high ACE score, like there probably has to be something a little more gentle. Like I think my physiology needs a little more gentle approach.
Well, that's where, things like, just body work, myofascial work can be very calming. Obviously breath work. EMDR is one of the newer techniques. There's a thing called parts work, which is some of the counselors would do. And it's almost like taking some of the body keeps the score concepts. Yes. Like you hold trauma in your body. Yeah. And then it allows you through realization, like, oh, that's the reason why I get this pelvic pain, or that's the reason why I get this certain abdominal pain, or I get tight, or I have these headaches. It's your body, your nervous system clamping down, and it's actually somatized previous trauma. And so it allows you to kind of take that and disassociate to a certain degree consciously, not not through drugs. And then it allows you to work through it. And because it's focused on your body, it doesn't have anything to do with the triggering kind of stuff. So there's a lot of really cool ways to work through it. In my conversation with Sachin, I actually agree with him on a lot of things, but this is one of the things we actually had concordance with, is like your breath work is an easy way to get there. And you can do like longer 2-hour sessions that actually act like disassociative, and you're using something natural, your breath, through hyperventilation, breath holding, to actually cause this disassociation. And then it puts you in a safe place where you can actually do some processing, some work. You don't have to have necessarily, Mother Ayahuasca kind of, which, and it's one of the things with that kind of stuff is that, if you do it in the wrong place, the wrong way, that can cause its own trauma. And if that happens, then you're really
you're in trouble.
Yeah.
You're really in trouble.
And how many, and I, you haven't, if you're going to ask this question, I'll answer for you. How many people do I see who we get 60% better? The hormones are kind of sort of better, but they're not quite stuck. And we kind of wash and repeat, look for mold again, look for Lyme again. Did we miss a concussion? Okay. We looked at your hormones again. And I do that 2-3 times because I need to do that just because there's not a test for this, so to speak. And then it's like, maybe you're not healing because of the cell danger response because of trauma. And sometimes it takes that for people to get buy-in to go down the route of whether it's primal trust or dynamic neural retraining, or there's so many things out there. It's just find what resonates with you and what you'll do.
Well, I think that's key because I know for a year, to your credit, you kept bringing up holotropic breathing. And I was like, no, I don't need that. So I found it to be really powerful. And I think sometimes when we're ready to do that type of work, it'll avail itself to us. I think one of the things about trauma that I have found so interesting is that when I was in my training years ago, trauma was really thought of as murder, rape, suicide. That's trauma. So I didn't think that I had any trauma in my life because, I turned out pretty good. I'm like, how bad could it be? But now that I understand the extent of what growing up in chaos and turmoil or drug addiction, parental drug addiction, those kinds of things, the net impact that can have on you long term. What I found interesting is while I was writing my book, which will be out next year, one of the things that really stood out was looking at people with high trauma scores, so high ACE scores, adverse childhood events. Anyone can go online and take that. It's a pretty short test. And earlier menopause. It was
one of the I wasn't familiar.
No, so the research from that has shown that women, like as an example, if a woman is sexually abused as a child, and then she goes on to have a family, and one of her kids gets sexually abused, like she will go into menopause 8 years earlier. So the effect of, whether it's epigenetic changes or just the growing up in that kind of chronic high sympathetic dominant state over the course of a lifetime, but looking at trauma as a proxy for earlier menopausal transitions, I thought was interesting from the perspective of these are things people aren't talking about. Yeah. It's like, first of all, perimenopause, menopause are having a moment, thank God, because I think it's important to have those conversations, but understanding that my childhood experiences probably contributed to going into menopause earlier than the average person does. And I thought that was really interesting, selfishly. And then I was like, oh, I've got a lot of friends that this makes a lot of sense why some of them were 47, 48, 49, going into menopause earlier than conventionally.
Well, just basic statistics that 25% of women have had some kind of trauma, physical, sexual, emotional abuse, 10% of men. And this is like the official, like anybody.
People who've disclosed.
Yeah. And this is like in the room, like everybody agrees this is trauma, right? This is not like questionable trauma.
Right.
Big T trauma versus little T trauma. But what got me down this pathway actually was from adopting our kids and our first daughter, child with special needs and the special need. And this is where like my spidey sense, my radar started popping up. It was like just from my wife who worked, she was a pediatric OT who worked with kids with special needs. And you would see in this world, like if your child's trach falls out like 3 or 4 times a year and they almost suffocate, like that's traumatic. Absolutely. If you have to take your kid to the ER for the 3rd time this month for seizures, that's traumatic. Like, and all of a sudden it's like in the special needs world, it's like every mom probably has, little T trauma of some degree, just dealing with these kids with special needs. Then my mind started to think, there's water torture, which is like dropping water on someone's head and you kind of go insane. And like I was reading some World War II books and reading about I think it was the Battle of Verdun, where basically it was like you had to do these little planks up to the front, and if you fell off the plank into the mud, you couldn't pull people out, so they would just sink throughout the day. And so the guys coming back at the end would find the people that had sunk like to here, and they'd literally gone insane throughout the day because they knew their end was coming, and they're slowly sinking in the mud, and you're going to suffocate to death, right? And so just that, the guys are coming back and seeing their friends who had lost their minds, and it's like, okay, that's an extreme short-term stressor. Then kid with special needs, like is there a lot of small T trauma just floating around the air that we're ignoring because it doesn't fit into the nice MACE box, And again, 25 and 10%. So if you add all this stuff in, maybe we all got something going on,
No, I think for each one of us, and I will be the first person to say I will be in some form of therapy for the rest of my life to kind of continue to fine tune the things that I grew up within. And it's not to suggest, I think parents do the best that they can, period. And so I'm grateful that I'm who I am, because had I grown up differently, I wouldn't be the person that I am today. But I think from a lot of perspectives that trauma is oftentimes an undealt with entity, whether it's the time constraints of traditional allopathic medicine, which I know you worked within. When I met you, you were still kind of had your feet in both, the allopathic functional integrative world and came fully over. But I think about a lot of our colleagues that are still in a system where they just don't have 30, 60, 90 minutes to spend with a patient to unpack some of those things that can take a long time for a patient to feel like they have the trust and rapport to be able to share that kind of information.
Yeah, and it's just hard, we have this thing, Connected Health, we're putting together. And one of the resources for people is like how to talk to your doctor. Because the reality is if every primary care doctor in the country went functional tomorrow, we would not have enough people doing this. When I was, when you first met me, I was taking care of about 2,800 people was my patient and panel. Now I'm like about 300. So literally I'm busy because people got a lot of stuff going on. But the point is like, if everybody went to functional, we would need probably 10 times more people than we have now just to be at the same place we're at now. And so the reality is people just aren't going to, the average person, it's going to be hard to have access. So to create resources that people can actually kind of get stuff. And trauma is just a part of that, like addressing those kind of things, addressing the stress. And if you don't, it's going to affect people's healing journey, which we all have a healing journey we need to go on. So.
Yeah, no. So I always like to express publicly how grateful and appreciative I am, because you have encouraged me gently to deal with my stuff, like gently. Okay, we're going to bring this up again. Okay. Eventually it's going to sink down and I'm actually going to move forward with it.
Just doing too much stuff. That's all.
Yes.
Let your life slow down. Just stop reading books and doing podcasts.
Yeah, exactly.
Work on yourself a little bit.
Exactly. Just scale back on everything. One thing that I think I've learned about an enormous amount of information from you is mold and mycotoxins. And I think for a lot of people, especially people that are not part of that 25% that are just more sensitive to mold and this kind of chronic inflammatory response, let's talk about how this can show up in middle age. Again, we know that our buckets are getting filled and filled and filled, and then middle age, sometimes that bucket overflows and then it becomes problematic. But when you're working with someone and considering environmental contributors to why they're inflamed or why their hormones, they're struggling to get their hormones properly optimized is a better word than balance, because balance is elusive. Help us understand, we also live in a very, very humid part of the United States. So mold is kind of always in the forefront of my mind, but how has that evolution come for you as well as a clinician?
I mean, great question. The way I'd start it is like there's two sides to this coin. One is the chronic inflammatory response syndrome, which is the innate immune system activation, which in that world, that includes, chronic Lyme, that includes post-concussive syndrome, it includes Pfiesteria, ciguatera, red tide, recluse spider bites, breast implant illness, vaccinosis, vaccine related. So it's a big tent, but 80% of that tent is mold. Is water damaged buildings is a more appropriate term, because that includes bacteria and other things. So that's one thing. But then there's just mold toxicity that just falls into the good old fashioned, we're exposed to lots of toxins and chemicals. So there's the people who get the immune system dysfunction, and then there's just getting exposed to mold, like in our food system, in our coffee and the grains. I just did on myself a fancy toxin test and had lots of mold in my urine. All my Sears markers are fine, but I'm like, yeah, I've been eating a lot more, grains in the last, couple
Peanut
of months.
butter.
Yeah, well, nuts, because something nuts in general. But the point is that, so those are two different things. And like, how's this evolve with my practice? I was brought into this kicking and screaming. When I first finished my functional training, I was like, I'm not going to deal with those crazy Lyme patients because they are kind of crazy. But if you were chronically ill and your brain was on fire, you would be a little crazy too, right? And then I'm not going to deal with mold because the same kind of thing. And think Dr. Ackerley, she's a psychiatrist in Maryland when I first did my training. And like what brought her in this world was bipolar patients who were getting better when she treated their mold. And it was like, for her, it was like, oh,
wow.
And so it's like, but I wasn't going to do this because it's like this. And so I got pulled in kicking and screaming because I started seeing like, well, this sounds like what I heard about in that lecture. Oh, God. No, I'm going to ignore it. And then three patients later, sounds like another one. And so I was like, well, let me just do the basic testing. And it took me a couple of months to realize is this really everywhere? Is it really, is the literature true? Maybe 23 to 25% of the population has this gene. Half the buildings in the country have some kind of water damage. Then if you take those numbers, this is an undisclosed epidemic. And so I got pulled in kicking and screaming. The same thing with Lyme. I don't want to deal with this, but when I came back from Florida and we got in the military, I had a patient who I checked and they had positive Lyme. I'm like, I'm going to refer them to the infectious disease doctor. And I called them and they're like, well, we don't take referrals for this because there's no Lyme disease in Central Virginia.
Oh boy.
Yes, this was 2008. So it was a bit ago, but like Lyme's been around for, a long time. And so I was like, well, I can just shoot. And then the primary care, family medicine side of me, I'm like, well, I guess I'll have to figure it out myself. Right. And I literally got pulled in this kicking and screaming. And then you start looking around and realize like, in the East Coast, from basically Central Virginia up, it's all red, and you start looking at the CDC data that there are more cases of acute, not chronic and not reactivated, but acute Lyme in our country than there are breast cancer cases every year. So this is more common than breast cancer as far as cases.
Right.
And all of a sudden, like, if you can't take care of this, you're not going to be able to take care of a lot of your patients. And so that I just got pulled kicking and screaming. And then the whole dysautonomia thing, I'm not, that's another rare thing. Ehlers-Danlos, like I'm not going to see Ehlers-Danlos patients because they're way too complicated because they have chronic pain and they dislocate this and that and the other, and they get their neck slides and it compresses their spine. And all of a sudden it's just really super complicated. And you realize it's a spectrum.
Yep.
And yeah, EDS is uncommon, but if you see enough people, you see it. But hypermobility, again, maybe 20% of the population. And something I want to say now is if you start reading like, the mast cell literature, maybe 20% of the population in Germany has mast cell activation syndrome. Okay. Then the gene thing here for mold, chronic inflammatory response syndrome, then the data. And the data is interesting from kids for adults because it changes, because kids get up, they get a little stiff, but 20% of kids have this, 13% of college students, they don't go out of it. It's just, we're not looking at it, but these are all kind of the same numbers, kind of, sort of. And then there's this thing called the pentad, which is 5 things you always look for. And it's gut issues, autoimmune issues, dysautonomia, hypermobility, and mast cell activation syndrome. And so, and that's called the pentad super syndrome. If you see one of those, you have to look for the other 4. Then all of a sudden it's like, well, oh my gosh, like these complex patients, and how is it's all playing in hormones. Yeah. If you have one of these things going on and your hormones are a wreck, but you got to do this stuff. And that's where it's like the layers of the onion and so I got pulled kicking and screaming into this, and I kind of like it. It's kind of cool. But initially it was not like, I wasn't looking for this.
Yeah. Well, and it's interesting when I worked in Northern Virginia. So I worked for a large cardiology group, and we saw a lot. I mean, that's the number, at least at the time, number 1 county in our state endemic for Lyme. So we saw a ton of Lyme, but it would show up in weird ways. Like we would have an 18-year-old in the ICU with complete heart block, which means their atria and their ventricles were not communicating, which was fixable. But we would see Bell's palsy. I mean, we just saw a lot of kind of unusual presentations, but got to a point where we were kind of forced to be looking at tick-borne illnesses. I think the one that I always found more concerning, which is now more popular, unfortunately, is Lone Star tick. Because in cardiology, in a lot of patients, you need to refer to surgery. And when you have Lone Star tick, a small percentage, I don't know the percentage, but it's a small percentage, will go on to develop a mammalian meat allergy, which listeners are like, why is that important? Because there's a lot of heparin, as an example, is a drug that's derived from porcine. So it's derived from pork. So if you have an allergy to mammals, you cannot get certain drugs. And so we would have patients who desperately needed bypass surgery who couldn't get bypass surgery because they had this mammalian meat allergy that would send them into anaphylaxis, and no one would touch them because of this. So I look at I have a healthy amount of respect for tick-borne illnesses. And I think if you live in most of the East Coast as a clinician, you have to have it as part of your kind of differential if you're talking to patients, because it is so incredibly common. But a lot of people don't get diagnosed when they have early stage symptoms. It's oftentimes when it becomes kind of diffuse and chronic and unrelenting. Like I have a family member that has chronic Lyme, and it has been incredibly humbling to watch their journey.
Yeah, and just it's part of the issue is just the testing. Like the recommendation from the CDC is you do an antibody dot blot test, which in half of people that are later found to have Lyme, it's negative. So the screening test is falsely negative half the time in people who have this. Like that's a horrible screening tool. So I never use that. I'll just do a Western blot test. But then if you use a Western blot, and I don't want to say lab names because I don't want to get, these are like big national lab names. I don't want to get in trouble. So, but there's a certain lab locally. There's two of them that I work with. One, their Western blot testing is not that good. So I use a different one that's even better. But that one's, two of the bands were taken out when they had the Lyme vaccine. So you might have like, and it's this weird thing where you have to have 5 bands and 3 bands IgM. And it's like this, it's like you roll the dice and you break the bones and look at the entrails. And like if you have like a high risk band, the question isn't like, why do you have that? If it's a 41, sure, there could be, Epstein-Barr or whatever reactivating or other things. But some of them like a 90, if it's positive, then like that means that tick bit you and had some piece of that in it. And then there's a whole thing where, well, it has to be attached for 24 hours to 48 hours or you won't get it. It's like, no. Like if the tick actually was attached to another animal, was feeding, fell off, attaches to you, you get it. You can get it within, some of the literature looks like maybe an hour. So really quick, And my anecdotal personal story is I live in the country, have a little farm, and I'm covered, I'm outside, I'm covered from basically here to all the way down. And I was in some tall grass. And so I know where I got the tick. Went to Whole Foods and I had my t-shirt on there like 4 hours later. And I had like a little, what was this? I saw. So I pulled it off. The next day I got a round red thing.
Oh, really? So that's unusual. You get that typical bullseye.
Yeah. Well, so I'm, me. So I'm going to do my herbs and my mandragraphis, my astragalus, and I'll do a little petunia and all kind of stuff. And resveratrol. And it got bigger. So I doubled my doses up and it was getting bigger. So on day 3, it was like my whole arm was red.
Wow.
And so I was like, okay, let me just take some doxy. Oh, I'm going to take some doxy, right? Next day it was gone. I was like, that was erythema migrans. That was from a tick. And it was on there for maybe the longest it could possibly been was 6 hours.
It's interesting. This was probably 1994, 95. I was at a friend's house. She was getting married. We were outside in New Jersey. I got bit by presumably a deer tick. And I'm one of these people my entire life. I get bit by a bug. I have this exaggerated response. And so long story short, I don't know, the following week, I'm seeing my internal medicine doc and she looks at me, she goes, I know you came in for something else, but I want to talk about that. She probably saved my life. I mean, at that time, I didn't have enough of an appreciation for Lyme, but I was put on, I think, 6 weeks of doxy.
Oh, nice.
So, that sweltered, but I always say like with profound appreciation, but I have to be grateful that I've been one of those people my entire life. I have these exaggerated, which is probably part of that histamine mast cell degranulation issue. I've probably been one of these people my entire life. I was like, it probably saved my bacon because how many people get bit don't have that reaction. And then, it's like a year or two later, a couple of years later, they develop some sequelae. And what's interesting, and I'm sure you can probably speak to this, is that the type of microorganism that the spirochete that Lyme and coincidentally syphilis transmitted same ways, actually, through saliva and transmission and sex and everything else. They're very hard to treat. They're elusive. They're smart. And so for a lot of people, they assume that they've taken a cycle of antibiotics and that has cured them. And in many instances, it hasn't. So if someone's listening, they've been treated for Lyme appropriately. What would be some of the common sequelae if they haven't either been on antibiotics long enough, or maybe they needed a longer course of duration? What can be some of the common things that you see in clinical practice?
Well, a lot of those things are going to be like that pentad stuff, autoimmune, gut issues, neuropsychiatric. you can have a lot of, and if you have, particularly if you have things like Bartonella, you can have dysautonomia going on with it. So you develop a lot of things, autoimmune problems. You sometimes, strangely enough, we used to use like doxycycline, the tetracyclines back in the 70s and 80s were actually used to treat different connective tissue disorders, rheumatism, rheumatoid. Before we had some of the other fancy medications, hydroxychloroquine, Plaquenil, which also is used for Lyme and tick-borne, And so the question is like, were we actually were these autoimmune expressions actually just undiagnosed tick-borne illnesses, And so Lyme disease is like the great imitator, just like tuberculosis used to be the great imitator before. Then, syphilis and tuberculosis were kind of head and head depending on what area you're in.
Yeah.
And now tick disease, Lyme disease is the great imitator. And to your point, it's the same. It's a spirochete like syphilis. And that was one of those things that you get it, you might notice a little ulcer. If you didn't, then 30 years later, you went mad.
Yep.
Or developed cardiac issues or had an aneurysm or whatever. And so, and it's really interesting. There's this, when I was doing my training with Dale Bredesen, who's a big Alzheimer's researcher at the Buck Institute. He's written a great book about this. If you have any loved one out there with cognitive decline, but it was a small study, like maybe 20, 30 people, but a third of the Alzheimer's patients, and this is all post-mortem, they're dead, had spirochetes on brain biopsies.
Wild.
So, and that's part of his thing is like infections, certain infections can be part of someone's slow decline. Again, being sucked into things I didn't want to do. In my career, I had several patients who would have massive attacks, let's say of Lyme disease in the middle of the winter here. And one of them was actually an EDS patient, Ehlers-Danlos patient, going through a very stressful relationship. This happened to her like a couple of times while I was taking care of her, where she had a major issue with her husband, big stress. And she'd come in with all of these red, multiple erythema migrans, like all over her body, and she'd test positive for Lyme.
Wow.
That would respond to doxycycline and it'd go away. And then now what I know is that Lyme likes hypoxic or oxygen independent tissue. So it likes connective tissues, like joints.
Yeah.
Well, if you have people that are a little loosey-goosey, that are stretchy, they don't have lymphatic issues. So they're going to have more tissue hypoxia, which is part of the pain and other issues with hypermobility, right? So all of a sudden it makes sense that subset is going to be harder to treat their tick-borne illnesses, because particularly with Lyme that likes low oxygen tension tissues, they're going to have even lower oxygen tension tissues, But the point was like Lyme is like, in my mind, is like Epstein-Barr. It's really interesting. Some of the COVID stuff, people getting COVID, and this isn't the published literature, getting reactivation of Epstein-Barr, CMV, as well as Borrelia burgdorferi, Lyme. And so it was already there to be reactivated. And so is Lyme, for some people, kind of like mono, you have the acute mono, you have the chronic, and you have the reactivation. Is Lyme the exact same way? And the answer is I clinically see that all the time, and there's literature to support that.
It's so interesting. So, when you're in this immunocompromised state, it can reactivate latent viruses, things that have gone dormant in your body. And I find this intensely interesting, especially because I feel like in the groups that we run and programs that we do and questions that we get for the podcast, women will say like, what in the world is going on with my immune system in menopause? Like, why all of a sudden is my immune system taking such a hit? And we know that estrogen plays this very protective role. And with the loss of estrogen, which is a normal function of aging if you live long enough, do you feel like women in your practice that are taking hormone replacement therapy tend to get sick less often? And the reason why I'm asking this is that it seems like it's this burgeoning field of trying to figure out like, where do we need to replace or optimize hormones to find, where's the sweet spot that they're going to confer the most benefits. There's a lot of attention, appropriately so, to heart disease, bone protection, brain protection. But I also think now appropriately after writing this book, how important immunity is in this stage of life, especially as we're getting older, because I feel like there's a lot of fear mongering around immune function in general. And then you throw in, the loss of hormones and it becomes this precipitous shift and change in our ability to fight off infections.
I mean, having balanced hormones is anti-inflammatory.
Yep.
So it's an anti-inflammatory state. And as you lose those hormones, particularly estrogen, as women age, you can actually track. It's a commonly known thing in internal medicine. Your SUD rate goes up as you age, your fibrinogen or your clotting goes up as you age. And so HSCRP tends to as well, which is a molecule made by your liver. It's an antimicrobial peptide, actually.
Oh.
Yeah, CRP, it's actually an antimicrobial peptide. So if you see an elevated CRP, the question is, where is the infection? Inflammation, but then once you do all your magic and you treat this, that, and the other and do the probiotics and look for stuff, if it's not coming down, the question is there an infection somewhere, like a root canal is not better, like reactivation, Epstein-Barr, Lyme, and hormones are a big part of that. Women, when they have, after you have a baby, you see more autoimmune diseases after delivery. And I had several patients with horrible lupus. Actually, one of them had chondrocalcinosis, and she actually ended up passing away from her lupus. Was pretty bad early on in my career, but she felt her best when she was pregnant.
Yeah.
Her immune system was balanced. Her lupus went into like a relative remission when she was pregnant. And so we know that, and it's 100% makes sense that when you go through a change of life and your hormones come down. Now, the tricky thing about it is if they come down in a balanced fashion and they're all equally kind of lower, you're not going to feel the same way as if you're having estrogen dominance.
Yeah.
It's a relative dominance, right? It's not like high compared to a 20-year-old. It's like high compared to your progesterone.
Right, which is in the toilet.
Yeah, exactly. But 100% is going to affect your immune system, 100%. And so, arthritis, there's a type of, I've multiple patients with this, a type of degenerative arthritis that postmenopausal women get, particularly in their hands. And it's like a rapidly progressive over years where you'll get like, just almost like it's a, what's the term for it? It's
contractures. When they get the ulnar drift.
Well, you will. Those are all things related to the severe, but it's a kind of name for it. It's basically a rapidly progressing arthritis in the hands, not rheumatoid, and it's especially prominent in women with low estrogen. So it occurs in menopause. It's kind of like your hands version of like in simplex chronicus, which is the thinness of your vaginal vault. And it's interesting that that's a hormone thing in postmenopausal women. So but the thing is, you have to know the person's tell. Yeah. Some women, it's going to be, I don't think as well, anxious. Some women, I got my cold sores, and now I'm getting aphthous ulcers, and there's a thing called Behçet's, which is this weird kind of thing where you get abdominal pain and vaginal ulcers and potentially mouth ulcers. I know it's another rare thing I've seen in my career because that's what happens, and hormone related, right? So your hormones are super important, but the way I say it, they're the icing on the cake. When you're 9, 10, 11, 12, living the best life, you didn't necessarily need all this stuff. You do a lot of development through it. And we're kind of, where we were kind of made was to kind of edge into this stage where we get this nurturing stage where we pass on our genes and we pass on our memes, where we kind of go into our nurturing stage for like the next generation. It's just a part of living, but with all the chemicals in the environment, which are neuroendocrine disruptors that mess up your hormones, that are driving their obesogens. They drive obesity. Microplastics is all the rage right now, but it's crazy to think that, something like 60% of plaques will have microplastics in them.
That is terrifying.
It's crazy. Yeah, it's crazy. Petroleum, that's what's come to the public consciousness now, is the idea that these dyes, food dyes in our food system, are petroleum distillates. Like brilliant chemists can take oil and turn it into blue 3 and yellow and all. Why do marshmallows have a blue dye in them? Like,
makes no sense.
It's when we were in Italy a couple of weeks ago, I was like looking at stuff. I'm like, the marshmallows here have no blue dye in them. It's like, why? And all these things actually affect our hormones, affect our immune system. So it's one of those things that hormones are an important piece of it, but you have to look at all these different layers and how they all interplay. And that's unfortunately, those are the kind of individuals I work with. And you have to work through all these layers of, okay, if you're hypermobile, do we treat your sleep apnea? People that are hypermobile need more. This is like your world, the protein world. Well, women going through this phase in life need more protein for lots of great reasons. If you're hypermobile, multiply it by 1.5. Like you need more.
I need more protein than I'm already eating. Amazing.
Well, what you need to do, and you can talk to your doctor about this sometime. You probably need to go, because this will probably escape my mind whenever. But you, at some point in time, you go in and get a urinary organic acid done. It looks at your amino acids, and that's where you see, are you getting adequate protein? And if those are still low in your urine, that means your body's holding on to them. right? Because excess stuff you pee out. And so all of a sudden it's like, whatever you're doing is not quite enough,
Where's does, when we're talking about nutrition, I think one of the greatest kind of corundums that we're in right now is, obviously I'm known for intermittent fasting, and I share with my community that I'm doing a lot less fasting to make sure I'm getting in 3 meals, because one of the things you challenged me to do is to gain 5 pounds of muscle, which has meant, wider feeding window, more food. And I've been doing that diligently for almost a year. Having said that, a lot of women struggle, and probably men do as well. They really struggle to get enough protein into their diets. Do you have any, because I know you talk about nutrition with your patients, do you have any like sneaky ways you get in extra protein? We can talk to patients about larger portions. We can talk about a whey protein shake. But what are some of the things that you have found to be effective when you're talking to your patients about their protein needs?
I'm not sure if your experience has been this experience, but when my wife was doing this and she was getting accurate protein, feeling great, losing weight, doing all the things that you write in your book and tell your people to do, it was hard. Like every day was counting was counting macros and weighing stuff. And it was just like, and she's not a professional bodybuilder. She's just, a 40, how old's my wife now? 47, 40.
A youngin'.
Yeah, young. They're just trying to get enough so she feels good, so she loses weight, so she sleeps well and all that kind of jazz. And so her hormones are balanced, And it's like, it's hard.
Yeah.
And so how do you do that with food alone, which I'm a big food forward, getting all the appropriate stuff. I think that the trick is supplementing with a good quality collagen and whey protein.
Yeah.
I think that's the trick. The trick isn't, because if you're using steak alone to do this, you're going to drive your cholesterol up, which is not always bad. And so I have some patients who, one of them thinking about particular who may be listening to this, who high performance. She's actually run gymnast, a 50-year-old ex-gymnast. It's kind of like, is there ever such thing? No, but it's like she felt her best when she was doing like a carnivore thing, and she just needed lots of protein. It made her cholesterol look horrible, and that was a big stressor for her. But she felt absolutely amazing. And it's like, so how do you do that without making and of course, if you have gut microbiome issues, lots of endotoxins, the saturated fats pull that over. So now you're going to drive up your HSCRP, endotoxins. So it's all a balancing act, and checking labs for this stuff to make sure that's, you're not hurting people is important. That's where I think just using, good quality whey protein, a good quality collagen, you got, and the devil's in the details. They have these, how many grams per scoop are you getting? And if it's like, oh, that's 5 grams, I'm like, okay, so you need at least 4 scoops. So getting a product where you can just put it in and mix it up with whatever you're drinking or your smoothie. But typically you probably, and if you want to get accurate protein, you probably need 2 of those scoops, which,
that's typically what I do. It's like, I'll get 40 grams of protein and I'm like, okay, check the box. And even with me being fairly sensitive to dairy, I can do whey protein a couple days a week without issues, just a clean protein that has, kind of limited ingredients. One thing that a lot of patients share with me at this stage of life, maybe early 40s, is that they don't feel as hungry. Now, I always think about like what's physiologically changing or going on that may be contributing to that. And I definitely think, this progressive loss of muscle mass, the sarcopenic issue that becomes of issue north of 40. What has clinically been some of the contributing reasons, or have you seen this clinically in middle-aged people that just tell you, I'm just not as hungry as I once was. I know that I need to eat enough protein, but I struggle because I don't intrinsically feel that deep hunger like my teenagers do.
Yeah. That's something I have not personally ran across a lot of, because in just my clinic, the people I talk to is just different world for many reasons. I tend to, as the older I get them, and I've studied different healing traditions, I tend to just say, listen to your body and trust your intuition. If you're healthy and your body, there's a saying in the Korean culture, it's basically, I forget the Korean phrase, but you eat till you're 80% full, the assumption is with the statement you're saying that you don't have elevated CPK enzyme levels, your inflammatory markers aren't off. Your nutrient status is good. You have a good, well-functioning GI tract and all those things. I'm gonna say, listen to your body. I don't see those people. I see the people who are like, they might not have an appetite because they have inflammation. That's part of when you have elevated cytokines. If your IL-6 is elevated, that's, the average cancer patient dies from malnutrition.
Yeah.
And so in those patients, part of the sarcopenia and inflammation is elevated IL-6 and TNF alpha.
Mm-hmm.
And those people literally don't want to eat. And it's like, and they end up dying. They've been basically eating themselves from the inside out. I mean, minus, metastasis and stuff like that. So is this lack of hunger like an inflammatory condition? And that, again, those are the people I tend to see, and so I'm going down these pathways of checking cytokine levels and stuff. If it's just you're healthy, you're doing great. I know you need more protein because I read Cynthia's book and listened to Cynthia. But I feel amazing that it's like, well, I would say listen to your body, maybe do an organic acid test, look at your urine. Because if you're getting adequate protein, you should have the urine amino acid testing will tell you that. And then if you did a urine amino acid with organic acid, then you'd also know your metabolism as well. That's one of those things where it gets a symptom.
Mm-hmm.
It can be a symptom of like, I don't need more. It could be a symptom of badness. And that's where, what's their weight look like? If they're overweight, that's an issue. If they're underweight, that's an issue. And that's where that question, it's a lot more nuanced than, simply, well, then suck it up and eat more protein or listen to your body, right? Because it depends on the situation. But that's, would be my basic thoughts.
No. And that's helpful because it gave me something to think about that I had not considered before when people come to me and say, I'm just not hungry. And especially, the camp of people that have been doing OMAD for 5 years and it allowed them to lose, 50, 60, 70 pounds. OMAD. One meal a day.
Oh, okay.
So someone who's been, eating one meal a day for years and years and years. And suddenly they're like, wait a minute, I'm not hungry for more food. So now you're telling me I have to eat more food. And I think that is different than what you were speaking to. But certainly I see a lot of people that have been over fasting, over exercising, not eating enough food for a long period of time.
That's a totally different situation right there. That's helpful information. Your hunger, okay, let's go to some dysautonomia stuff. Like basically this part of your hypothalamus controls your temperature. It controls your hormonal cycle stuff. Your hunger. Mm-hmm. And so if you've kind of been doing a one meal a day for years, you're going to rewire your brain a little bit. So it can be, and you're doing that. The question is, what's the reason? Now there's a lot of medical reasons why you might do that.
Right.
Like Dr. Walls, her whole thing is around that. And I mean, she's kind of treated her multiple sclerosis. So that's amazing, right? It's certain situations that I think it comes down to like, there's a diet that's amazing for everybody. That's horrible for you, Vegan. There's some people that's amazing for. If you're hypermobile, being vegan when you need tons of protein and you tons of trace minerals, that's how those are the people who come see me 5 years later and we have to work through a lot of the health issues. Carnivore is amazing for some people. And that tends to help. That tends to be my hypermobile patients have had tons of micronutrient deficiencies. A GAPS diet. Mm-hmm. My autistic kids had a kid with acute demyelinating encephalomyelitis, AD. It's super rare thing. And basically his mom used that diet with some things to actually help his brain to heal. Incredible. So there's so many types of really cool diets that work in different situations. But if you're doing just one meal a day for like 5 years, then that's a stressor. Mm-hmm. And if you've been doing that for 5 years in your cycling age, that's a high cortisol state. Yeah. Maybe you just reset your midbrain. And that's a bigger issue. So probably that person I would highly recommend getting in-depth nutritional evaluation. Look at your fatty acids. Yeah. Look at your omega-3s, omega-6s, your long-chain fatty acids, your C15, which is all included in the testing. I won't say a basic, but a big fatty acid test. Looking at your amino acid levels, looking at mitochondrial function, glutathione. I mean, I would be curious if those people's glutathione levels are low.
Yeah. Well, it makes a lot of sense. And it's interesting, that bioindividuality piece is really key. Like one of the things I've learned working with you that I always gravitated towards lean protein, lean fish. And it's because the way that I'm a hyper absorber. So no wonder why if I ate a really fatty meat, I just felt sick, nauseous, my gallbladder's healthy. And you said to me, you were like, you probably have always gravitated towards leaner meat, chicken, fish. And I was like, yeah, but I didn't understand why. Now I do. My body just soaks it up like a sponge. So now we've got me on Zetia and I don't do that as much anymore, which I think is certainly very helpful. One thing I'd love to do, I'm kind of thinking this might be part of these, quick round, like easy to answer questions kind of towards the end. One food you recommend most often?
Bone broth.
Bone broth. Even so, if someone has issues with like histamine, do you have to kind of?
Well, you said. Yeah.
That's where my brain went.
You're getting tricky. You're getting tricky on me. Like just the one thing
super nourishing
that we're deficient in there. And I know you're a big fan of certain mineral supplements, right? For your fluids and stuff.
Yep.
And like we have a nationwide epidemic of micronutrient deficiencies, particularly in these rare earth minerals and these trace minerals. And, think about a cow. Where do cow bones come from? Where's the calcium in milk come from?
Yeah.
If you eat grass, you vomit. Your cats eat grass, they vomit. Your dogs eat grass, they vomit. Cows literally take that, ferment it, suck out the and they eat 16, 18 hours a day, and they concentrate that into their structures, into their body. And then you get the ability to basically get that without eating like, I don't know how many tons of grass, right? And so who eats organ meat anymore? We do it low fat, and now there's a whole thing with processed meat that's coming to one of the podcasts I listened to that they're talking about now. Basically, using grow meat, and incubator, and this is going to be the next big thing to solve world hunger. I'm like,
no,
what kind of broth? I mean, that's like the whole growing plants in like water with fertilizer. It's like you make green plants, but they don't have all this information from the soil and stuff. But what's the single source for a lot of stuff? It's bone broth.
Mm-hmm. And
it's easy to make. It's cheap. It's expensive if you buy in the store. It's easy to make. And you can make it in soups. You can just drink it. It's really easy.
That's one way you can get some protein in your diet if you're struggling.
Yeah.
When we talk about trace minerals, can we identify for listeners what you're specifically speaking to? Because they might be like, okay, I know, potassium, magnesium, sodium, all are very important. What are the trace minerals?
So there's trace minerals like zinc, manganese, copper, molybdenum. Then there's rare earth minerals like lithium, strontium, barium, silica. So there's things you need like 8,000 milligrams a day of like potassium. There's things you need like 30 milligrams a day of like zinc. There's things you need like 500 micrograms a day of like iodine. And there's things you need like picograms of.
Really tiny.
And the thing about it is if you don't get this stuff, you get these weird diseases. We don't really know what it does. And that's the cool black box. I learned about this from raising cows because I wanted my cows to be healthy. And I learned that cows that are fed grain, which only has about 60 of these trace rare earth minerals in it, tend to get certain illnesses.
Interesting.
And when you take a grass-fed cow and you supplement them with kelp, and Joel Salatin is a guy who actually learned this from, and one of the things that happens is the cows that are raised organically will go blind. They'll get eye infections and go blind.
Wow.
So if you go to an organic farm, because you can't use antibiotics, right? You'll see blind cows. He's like, that hasn't happened to me. And I was talking to him about this 10 years ago. So maybe 30 years at this stage. Like I haven't had a cow go blind in 20 years. All I do is supplement them with kelp.
Wow.
And that was where I was like, wait a second. Because then with goats and horses, they have certain deficiencies you have to supplement with. And so these are the things that cows get when they eat grass.
Right.
We don't know what it does for cows, but we just know they need it. And then, right? That's so many things, right? It's
herbivores.
Yeah.
Yep.
And where do humans get that stuff from? Where are you getting your lithium from? Well, maybe you're getting it from your lithium supplement, or you're getting it from eating something that concentrates it for you.
It's so interesting.
Yeah.
Thank you for clarifying that, because I know that'll be a question.
Yeah.
What's one test every woman over 40 should consider?
One test. I'm only allowed one. That's going to depend on the week you ask me that question.
Okay. Well, it's this week.
So today it's going to be a fatty acid analysis.
Okay.
Which is a trick answer because it's actually 20 different things in one test.
And what is the test? So I know we didn't want to talk about tests, but I'm sure we'll get asked, like, what is your preferred test?
I use Genova for that.
Okay.
They have a really affordable, it's like $150 for a fatty.
So when I see you tomorrow, we're going to be ordering this test.
Of course. We probably already have done it on you, to be honest with you. It's probably buried in the stuff that we overwhelmed you with.
Yes. And what is one thing you wish more doctors understood about inflammation in middle-aged patients?
That it's more than just a symptom. That can also cause disease. and don't blow it off. You asked me one thing. That's more than just a symptom. It's just something else is going on, and it can show up as a mental health issue. Joint aches and pains, fatigue, brain fog. It can affect your hormones. And so if you ignore it, it's like, what did I just describe? Like how many people you know? Like tons. Yeah. And it could just be inflammation that can be worsened by fatty acid deficiencies, nutrient deficiencies, gut issues, your chronic infection. And so appreciating that inflammation it's inflammaging. It makes you age quicker, and it's more than just a symptom, and don't ignore it.
Oh, thank you. This has been an invaluable conversation. Please let listeners know how to connect with you outside of this podcast, information about your practice. I know you're not currently taking new patients, but you have providers in your practice that are taking patients. Learn more about your work and get access to your podcast.
Sure. Yeah. Well, on my website, Richmond Functional Medicine is the hub for everything. If you Google my name, Aaron Hartman, MD, it will take you there. I am starting actually a precision medicine clinic, which is my way of trying to take everything I've talked about and just like I've done with my daughter, apply it to individuals. And that's hopefully launching here in the next couple of months. I actually have a book that's coming out I actually finished my third edit of it today. So, and Becky's looking at it and adding some things into it, but that's called Uncurable. It's actually my daughter's story.
Interacting
with the healthcare system and how how it changed literally my entire career. Like what I'm here right now because I adopted a girl that the doctors wanted to put a feeding tube into, and we refused to do that, and it's led to this totally different. So, but if you want to learn more, the podcast is Made for Health, which is on our website, Richmond Functional Medicine, YouTube channel, all the kind of things. I'm just trying to educate people about all this stuff because I feel like, if I believe what I say I believe, then 80% of chronic health issues, heart disease, 7% of cancer can be prevented by diet and lifestyle alone. And people knowing that, it can literally change their health trajectories. So
incredible. Thank you again for your time today.
Well, thanks for inviting me.